another session of Burning Migraine Questions. I'm Dr. Ziv Peled, plastic and peripheral nerve surgeon with a reasonable amount of experience doing surgery for chronic headaches / migraines. We have a very, very packed show, so to speak, for you today. We have a lot of interesting questions that continue to pile up. And so as before, I will certainly try to get to as many of them as I can. One of the first and easiest questions is, does the lesser occipital nerve area, or lesser occipital nerve, innervate areas typically innervated by the auricular temporal nerve, or does it innervate further up the side of the head? Interesting question, and actually these two nerves do have somewhat of an overlapping nerve territory. The lesser occipital nerve emanates behind the sternocleidomastoid. That is this muscle that you can see bulging out of my neck right here. It emerges from behind that sternocleidomastoid and basically, generally speaking, goes in this direction. The auricular temporal nerve emanates from above the helical root. That's where this part of the ear meets the rest of the skull, and it comes out near the parotid gland right here in front of this little nubbin at the beginning of your ear called the tragus, and continues up here, often branching as it gets closer to the top of the hairline. So as you can see, these two nerves can have overlapping nerve territories, and the answer to the question is therefore perhaps. What I tell all my patients is that every person is literally wired differently. And what I mean by that is I can show you pictures of the auricular temporal nerve in one patient and the auricular temporal nerve in several other patients, and all of the branching patterns will be slightly different. It is for these reasons that it is exquisitely important when you're doing nerve blocks as diagnostic maneuvers that you only block one nerve at a time. Because if you have pain, let's say in this area, and you block the auricular temporal and lesser occipital nerve at the same time, and all that pain goes away, you do not know which nerve that you blocked was responsible for elimination of that pain. It could be it could be one, it could be both. If it's just one, you don't know which one. So you need to eliminate them one at a time. And so if you block the auricular temporal nerve and all the pain goes away, it's probably mostly as a result of the auricular temporal nerve. If you block the lesser occipital nerve and all of this pain goes away, it's probably mostly the lesser occipital nerve. If the pain's 8 out of 10, and you block the auricular temporal nerve and it goes to 5 out of 10, and then you block the lesser occipital nerve and it goes to 0, then it's both nerves that are probably involved. And that's, in a nutshell, how the diagnostic process works with respect to nerve blocks. There's a great question here. How does a patient know if they're a candidate for a second operation or second decompression if the first one failed or only produced partial success? So I think we've touched upon these in prior Burning Migraine Question sessions, but this is a question that is very important, and so let's go over some of these things again. If you have failed an initial procedure, initial decompression, let's say of the greater occipital nerve, and you still have pain in the back, that could mean any one of several things. It could mean that the nerve was permanently damaged, that is the nerve that's involved, and that simply decompressing a nerve was not enough. The nerve is still damaged. It was damaged on the inside, so the external pressure on top of it, now having been removed, is not enough to ameliorate your pain. If that's the case, then transection is an option. That is still, I think, what most people would do. Most recently, I've had a number of patients on whom we have done a re-decompression, so decompressing it again, with the presumption that excessive scar tissue has formed around the nerve and recompressed it. Now, scar tissue will always form anywhere you make an incision, and it also forms underneath the skin in the muscle and connective tissue that you dissect. The key is to try to make enough of a space around the nerve and to fill that space with fat, for example, in the case of the greater occipital nerve, to pad that nerve against further scar formation and compression. But if you have excessive scar tissue formation, that nerve may become re-decompressed. In that case, I have a number of patients now with whom we've done a re-decompression, and now doing the same thing and hoping for a different result seems to be the definition of silliness. And so one of the things that we've started to add is the umbilical cord wrap that we have discussed at one point in prior episodes. And the idea behind this product is that it will reduce not only inflammation around the nerve from that additional dissection, but it will also help prevent scar tissue formation. As of this time, there is no specific published data on the efficacy of using these umbilical cord wraps in this particular case. They're used with some frequency for other essential nerves after trauma, for example, in the upper extremity, like the median nerve or ulnar nerve, where the data seem to be growing that in revision, neurolysis, or scar tissue removal cases, this umbilical cord wrap can be effective, and so a re-decompression is possible. Another reason that a patient might have failed the first operation is that a nerve was missed. So as I'm sure I've said in prior burning migraine question episodes, when you have a person on whom you're operating on the greater occipital nerve, it is almost always the case that doing an adequate dissection of that nerve will expose the third occipital nerve. And so if the third occipital nerve was compressed in the first place but was not recognized as a problem and therefore not addressed during surgery, or potentially was injured during surgery, that patient could still have residual pain. It may not be the exact same kind of pain, same intensity, or even same location as the original greater occipital nerve pain. In fact, it probably will be slightly different. But if you say you only have partial relief because, let's say, a nerve was injured, by mistake, of course, during that first operation, you might only have partial relief, and therefore that is a different surgical approach than re-decompressing or transecting, meaning cutting the greater occipital nerve. And so how do you know if you're a candidate for re-decompression? The workup is exactly the same. You need to be reevaluated by the headache surgeon, and you need to perform sequential blocks after being examined, and after which point you have determined, well, it could be nerve X, Y, or Z. And once you have identified those potential nerves, sequential blocks thereof will help determine if blocking those nerves relieves the pain. Then you are potentially a candidate for something related to those nerves. So a re-decompression or transection of the greater occipital nerve, or if you inject more caudally over the third occipital nerve and you find that that is now providing that remaining relief because you had a partial result, then the reoperation, the revision procedure really needs to address just that third nerve. So that was an excellent question. Really appreciate that. Can occipital neuralgia cause symptoms or pains to other parts of your body? Again, a very, very good question, and I think that it's not necessarily the case. So let's say I was talking with a patient of mine just the other day who's gotten some relief from his occipital neuralgia procedure, but he noted to me that he now has some burning and tingling in his leg. Okay, that started several months after surgery. I never had it before, and when he initially presented to me, something he neglected to mention was that he had this kind of testicular or groin pain. To my knowledge, and it does not make any anatomic sense, that occipital neuralgia would cause groin pain or leg pain or pain in the upper extremities, for example. However, the fact that you have pain in a number of different nerve distributions throughout the body may suggest that there is a more systemic neuritis, so some type of systemic inflammation or irritation of the nervous system. Osgood-Schlatter syndrome is one example of such a problem. People who have Lyme disease can have all sorts of nerve symptoms throughout their body. Shingles or as the doctors would call it, post-herpetic neuralgia, is certainly a syndrome that can cause nerve irritation in many parts of the body, usually only one dermatome or nerve root and its downstream branches are affected at any one time. But if you have various pains at various times, you might simply need to be tested for post-herpetic neuralgia and go on a course of antiviral medicines whenever you have a flare. So in this particular case, I would say occipital neuralgia does not, as far as we know, cause, for example, lower extremity or leg pain. But if you're starting to have occipital neuralgia and other pains, other nerve type symptoms in the trunk and the lower extremities, then maybe it's time to look for a more systemic cause. Another patient sent in an interesting question, which is that she fell down the steps, hit the lower part of her head and her lower back, and has been in horrible pain ever since. She has any number of symptoms, including dysesthesia or altered sensation. She says that her hair basically hurts. She hates to have anybody touch this. And the question is, what's going on. I assume, and we don't know because this person didn't include this in their question, that they have been ruled out since there was a fall or some kind of trauma for any intracranial damage. So you need to make sure that, for example, they don't have a subdural hematoma or an epidural hematoma, because those can be surgical emergencies and are things that need to be addressed with some swiftness, usually by a neurosurgeon. And I assume that there's no other evidence for injury in the cervical spine. So, for example, you get an MRI or CAT scan of the cervical spine around the time of the injury to make sure that you haven't fractured one of your vertebrae, you haven't herniated a disc that is now pressing against a nerve root, or transected any particular nerve root, or potentially even torn a muscle. So assuming that all of those are negative, what this woman is describing, and one of the hallmarks that supposes or suggests this diagnosis is the more accurate one, is the dysesthesia, that altered sensation to the skin. Because while, for example, greater occipital neuralgia can present in any number of ways, one of the classic symptoms, not 100% of the time, but one of the classic symptoms is that altered sensation, dysesthesia. And so in this particular case, if you've ruled out many of those other types of injuries and you have a good physical exam that is consistent with, let's say, greater, lesser, or third occipital neuralgia, and you respond to nerve blocks, meaning your symptoms temporarily get better, not necessarily 100% better, but significantly better with a nerve block or several nerve blocks, one after the other, then you probably have occipital neuralgia. Now, one of the other questions that people ask is, well, how come the MRI was negative? They didn't see anything. Can't they see these nerves? And that's a great question. The simple answer is oftentimes no. These nerves are really, really small, especially the lesser and the third occipital nerves. They're sometimes even hard to find in the operating room with high-powered loop magnification. Those are these magnifying glasses that we wear to help identify these small nerves. And so imaging these things on an MRI may not be possible. The nerves are really tiny, and they're going to appear as really small little pixels even in the highest resolution MRI scanners. Now, currently, the highest commercially available MRI magnets are what are known as 3 Tesla magnets. They give you very nice images, but still really only image larger nerves like the sciatic nerve, which can be as thick as 2 finger breadths in larger men, nerve roots, which are usually about as thick as your thumb coming out of the spinal cord. Those nerves are big enough to accurately be imaged and to identify when they're pinched or where there's inflammation of those things. If you have a nerve that's the size of 1 pixel on your MRI and that nerve is pinched, you probably will not, A, recognize that that is a nerve, or B, recognize or be able to tell if that nerve is impinged. We have MRI technology that continues to advance very quickly. There are a few places, usually research institutions, where you have 4.5 Tesla magnets, and I'm told in Canada, this is a bit of a rumor, that there's a 9 Tesla magnet floating around somewhere. I would love to see images generated by that machine, but it's certainly not going to be available for commercial use anytime soon. The other question that, getting back to that issue, how come the MRI was negative? They didn't see anything. It's not true that they didn't see anything. They saw that you don't have a herniated disc. They saw that you don't have an epidural hematoma. They saw that you didn't tear a muscle or pinch a nerve root. What they can't tell you is that the nerves are, let's say the third occipital nerve hasn't been pinched, or that there hasn't been a stretch or traction injury on those nerves, which is what most cases of whiplash, where you have chronic pain, are. In other words, most of those cases, you don't have any ligamentous tear, but there's been a traction or stretch injury of these nerves that has either caused scar tissue to form around the nerves, thus compressing it, or actually torn and scarred the nerve itself, thus causing dysfunction and discomfort. Very, very good question, and thank you for that. Next patient asked, is burning the nerves suggested? And I assume by burning the nerves, they're talking about something known as radiofrequency ablation. So let's talk about that very briefly. My disclosure right off the top of the bat here is that, right off the bat, not the top of the bat, right off the bat is that I don't do radiofrequency ablation procedures. Like any procedure or operation, in the right hands with a good practitioner who's doing the right thing for the right reasons, you can have excellent results. But I am somewhat biased against radiofrequency ablation procedures as an initial operation or procedure before surgery for this reason. The way radiofrequency ablation works, in my understanding, is you have a probe, and at the tip of that probe, there is a tip that vibrates with high frequency. It's a radio frequency, and by vibrating very quickly, it generates a thermal zone of damage. Think of it as a candle. If you think about a candle, there's that kind of teardrop or eyelid-shaped flame, where the hottest flame is that blue flame right near the tip, and then there's a red flame, and then there's the yellow flame, which is the least hot, right at the very, very edge, okay? So if you have a nerve sitting here, and you have the radiofrequency probe sitting here, when you put that probe to try and get that nerve to ablate it, okay, you have to be right on the nerve. Most people will do these types of procedures under what's called fluoroscopic guidance. Fluoroscopy is basically a real-time x-ray. It's an x-ray that runs like a film, and like x-rays, in most cases, you do not see the soft tissue structures. You won't see the nerves, but you will see the bony landmarks around which the nerve is supposed to be. So if you have a bone here and a bone there, and the nerve is supposed to be in between, that's where you put your probe, and you assume that the probe is going to be right on the nerve. Now, if you have the nerve here, sorry, this nerve, and you have the probe here, and the probe is nowhere near the nerve, and you turn the machine on, you're going to have the flame kind of go over here, and it won't touch the nerve, and so in that case, you'll have no result at all, okay? And in some cases, that's what happens with radiofrequency ablation. In some cases, you have the nerve here, and the probe gets put right on it, and you turn it on, and basically the hottest part of the flame gets the nerve, and you can completely destroy that nerve. And if that's done within the muscle as the nerve passes through the muscle, that might be as effective as going in there and cutting a permanently injured nerve and burying it in the muscle. And so you might get away with a permanent result, much like you would with surgery. So in that case, you've kind of hit a home run, if you will. In some cases, in many cases, you have the nerve here, or let's say it's this, and you have the probe here, and it's just nearby. And one of two things is going to happen in this particular case. The flame is only going to be yay big, and so let's say it's only the yellow flame from the radiofrequency probe that hits that nerve. In that case, you may only get a partial result, and partial can mean any number of things. You only get 50% relief, but for 6 months. You get 100% relief, but only for 2 weeks, and then it comes back. The other thing that can happen when you have a radiofrequency probe near but not directly on a nerve is that you can actually potentially, just like with surgical intervention, actually injure that nerve because you irritate it, if you will, with the radiofrequency probe and whatever thermal zone of injury you create, and actually cause more scar tissue. And in that case, in some situations, the nerve can be injured permanently. And I have several colleagues, which, and this remains an issue, philosophical issue amongst us. We don't have any papers that suggest that one or the other is the best course of treatment, but some of my colleagues will say if you've had a radiofrequency ablation procedure on, let's say, the third occipital nerve, we're going to cut that nerve no matter what, because my presumption is before I go in there that that nerve has been permanently injured. And I personally take a wait and see approach. I get in there and I see what the nerve looks like, and if it looks really healthy and amazing, then I will save it. But a lot of people always ask me, well, if I've had radiofrequency ablation, if I've burned the nerve or tried to burn the nerve, but it didn't work, does that affect your operation? In my hands, the answer is it doesn't necessarily change what I would do. I always decompress any particular nerve first before deciding whether or not I'm going to cut it. However, the chances that I will be able to preserve a nerve that has had some type of ablation procedure on it already is less than if that procedure had not been performed, because the whole point of the radiofrequency ablation is to shut that nerve down, or ideally completely destroy it and inactivate it, okay? And so typically that does cause some injury. Most of the time it's not permanent, but sometimes it is. And it's for that last reason that I tend to suggest that if you're thinking of one versus another, again, I admit I'm biased because I'm a surgeon, but I prefer surgical intervention over radiofrequency ablation. The other rationale there is that obviously surgical intervention is a surgical strike. You make an incision, you use microneurosurgical techniques to really define the nerve and only one nerve, and you know that you've gotten it because you can see it and you can manipulate it, whereas you are indirectly treating it because you don't actually see the nerves with fluoroscopy guidance. That is often what people use during the radiofrequency ablation procedures. So thank you for that question. Another person suggested or asked the question, I have a lot of nausea associated with my migraines. Will surgical intervention relieve that? The simple answer to that question is we don't really know. It is unclear why some people have severe nausea. I saw a patient like this yesterday. One of their main symptoms is severe nausea with their migraines. They also get vertigo. And so what's causing the nausea? You can imagine if you have significant debilitating pain that is enough to cause you to become nauseous. If you've ever been punched in the stomach and lost your breath, sometimes you get nauseous with that because you hyperventilate. This particular patient has migraines with vertigo, and so the vertigo as a secondary symptom of the migraine can cause nausea. It's not the headache itself that does it, but the vertigo associated with it. And in some cases, you just never really know why people get nausea with their migraines. One of the benefits of nerve blocks that I tell my patients is that you not only get to test drive the sensory feelings that you may or may not have after surgery. In other words, you numb a nerve, you get to test drive what it would feel like if I were to cut that nerve and you had none of that sensation. And you're going to feel that for a few hours, but if we cut that nerve, you're going to feel that way or something very similar, potentially permanently. Now, if you have a lot of nausea with your migraines, one of the reasons that I like nerve blocks over Botox is when the patients come into my office in as bad a state as they can be and actually still walk into the office, and they have nausea, which is typical for their migraines, and I inject the nerve or nerves that are involved in the generation of their migraines, if their nausea improves, then more often than not, post-surgically, the nausea will also go away permanently. So the answer to the question, will surgery relieve nausea associated with migraines? It's certainly possible. I have a number of patients in whom their biggest complaint was not necessarily head pain or burning, but horrible nausea that went away when we blocked them because they came in horribly nauseous and vomiting. They left feeling amazing and went to have lunch. And post-surgically, their nausea is as absent as their migraines. So the answer is certainly possible. We've talked about whether surgery is, decompression surgery is similar to RFA. Hopefully that makes sense. Let's see, if one doesn't respond to nerve blocks, are you not a candidate? Well, the simple answer is yes, okay? But as I, again, say to all my patients, there are nerve blocks and then there are nerve blocks. And what do I mean by that? Well, the results of a nerve block are going to be affected by four main parameters. First of all, obviously, what you inject. If you inject, half a cc of very short-acting local anesthetic, you may not feel much of a result. So, one, what you inject. Two, how much of it you inject. In other words, if you inject just the right amount in just the right place, you'll only get one nerve. If you inject a gallon of local in the back of the head, you might block 10 nerves with one shot. And then if all the pain goes away, you don't know which nerve that you blocked was responsible for that result. Okay, so one thing that affects the result of nerve blocks is what you inject. Two, how much of it you inject. Three, where and how you inject. Obviously, you want to get as close to the nerve as possible so that you get as many of the nerve fibers that comprise that nerve as possible with your block. While at the same time striking a balance between not blocking if there's two nerves near each other, putting in a gallon and blocking all of them at the same time. So ideally, if this nerve is here and this nerve is there, you want to put your needle closer to here, where even if you inject a couple of milliliters, you're still not going to get this nerve. Whereas if you inject right here and inject a couple milliliters, you may get both. So one, what you inject. Two, how much of it you inject. Three, where and how you inject. And four, probably the most important thing, for what reason you are injecting. As I've said before, and it bears repeating, you can't say it enough, nerve blocks are not treatment modalities. They will not fix you because, like any medicine, it will wear off. And when it wears off, if the problem is a mechanical compression of the nerve, the pain will return. If you have diabetes and your blood sugar is high and you get a shot of insulin, you don't go, that was easy, I'm done, I don't have to do anything. No, you got to watch your diet, you got to check your blood sugar, and you got to inject insulin again, depending on what that blood sugar is. And nerve blocks work exactly the same way. They are diagnostic modalities, not treatment modalities. So again, a very long-winded answer to your question. The nerve blocks didn't work. Does that mean surgery is not possible? Maybe. And one of the hallmarks that I've asked my patients, and I'm always amazed at the results and the answers, I say, you got a nerve block, let's say the greater occipital nerve, were you numb at all in the back of the head? And they'll say no. And what that tells me is that the doctor missed. They didn't get the greater occipital nerve because you weren't really numb like you're supposed to be after you blocked the greater occipital nerve. And in that case, then the nerve block hasn't told you anything because you didn't actually block the nerve you thought. There was one last question that was asking, what if you have a nerve stimulator implanted in the cervical area? If it's not successful, does that preclude you from having surgery? The answer is no. It is a piece of hardware, much like a cardiac pacemaker or heart pacemaker for your heart, but in this case for the nerves. It's important to have imaging. Usually x-rays are sufficient in this particular case to see where the leads are and where they might be in relation to the nerves you're going after. And especially if the nerve stimulator has been turned off because it's been ineffective, mobilization of those leads, which is probably what you're going to need to do in order to adequately address or get at and decompress or transect any particular nerve, is going to be necessary. So you're going to have to move those leads. So in the case where the nerve stimulator is ineffective and the leads aren't working anyway, that doesn't really matter. And so the answer to that question is no. Presence of a nerve stimulator does not preclude the need for surgery. There are certain precautions you need to take in the operating room. The first and most glaring one is that you should not be using, especially if the nerve stimulator is still active, a regular Bovie cautery. That's a cauterization device that we typically use because a monopolar cautery can actually short circuit the lead generator. That is the thing that creates the electrical impulses that are supposedly making those nerve stimulators work. So if you have a stimulator that's working and let's say providing even 15% relief and you use a monopolar cautery in the operating room, you could actually destroy that device. Okay, so one particular technical modification that you might make is using a bipolar cautery exclusively, which I use in most cases when I'm working directly anywhere near nerves anyway, because it's just safer and will decrease the chance for any thermal damage to the nerves themselves. And finally, one last question. A lot of surgeons have any number of different incisions to get at this nerve or that nerve. For example, I have a very esteemed colleague whom I respect tremendously, and who's written a lot about occipital neuralgia, who makes transverse incisions, that is 2 incisions kind of going horizontally to get at all of the occipital nerves. I make 3 incisions, 1 larger one in the midline and 2 smaller ones on the sides. Which one's better? Again, I think that it gets a bit technical, but the upshot is that the location of the incision at the skin is actually meaningless as long as you can do what you need to do underneath the skin, because the nerves are deeper underneath the skin, either within the muscle, around blood vessels, or connective tissue. So if, and like with many operations, there are any number of ways to approach that particular problem. So as long as you are able to adequately decompress a nerve from all that connective tissue, muscle, and around blood vessels, whether the incision is horizontal, vertical, or zigzag, it doesn't matter. All right, we are actually out of time. We still have a whole host of questions, so please keep them coming. Really appreciate this. If you have any other questions, feel free to go to the Peled Migraine Surgery Facebook page or follow us at Peled Migraine on Instagram, and we'd be happy to add your questions to the list for a future Burning Migraine Questions episode. Thank you very much for joining us, and we'll see you in a couple of weeks. Take care.